Okay, I think we can get started. Good morning, everyone, and thank you so much for joining us today. We're very excited to share highlights from the Max Foundation's 2025 Monitoring and Evaluation Report, not only to reflect on our progress and impact, but also to share what we're learning and where we see opportunities to strengthen access to care. We're especially glad to have many of our partners join the webinar today. This report is not just a reflection of the Max Foundation's work, but what we're able to achieve together. I'm also very pleased to be joined by my colleagues, Liat Granati, our Communications Manager from Latin America, Kathy Skeepers, our Region Head for Africa, and Mei Ching Ong, our Region Head for Asia and Eastern Europe, who will share reflections and examples of their work across our programs. As we move through the presentation, please feel free to post any questions or comments in the chat, and we'll come back to them at the end during the Q&A. So this slide gives a high overview of the M&E framework that guided the report. So we organize our M&E report around three main objectives that drives our work. The first objective focuses on patients, specifically whether we are reaching more people with treatment and care across more diseases and countries, and whether patients are able to stay on treatment over time. The second objective focuses on health systems. This is about the broader environment around patient access, including country expansion, partnerships, diagnostic capacity, site assessments, and healthcare professional training. And the third objective focuses on the value of investment. And these indicators help us look at how resources are being used responsibly and translated into impact. So our first set of indicators focuses on patients. These indicators aim to measure patient reach and whether patients are able to access treatment in a timely and sustained way, with the ultimate goal of improving survival, quality of life, and economic well-being for patients. This first indicator looks at the total number of patients reached across our programs. In 2025, the Max Foundation reached 40,561 patients worldwide through our treatment access program, Max Access Solutions, our social determinants of health programs, and the treatment-free remission support program. This number represents a 2.3% increase from 2024, and importantly marks the first time we've reached more than 40,000 patients globally in a year. So Max Access Solutions is the Max Foundation's core treatment access model for patients in low and middle income countries. Through Max Access Solutions alone, 38,287 patients received medicine in 2025. That was a 2.8% increase from 2024. We enrolled 4,932 new patients, representing a 16% increase from the prior year. In addition, approximately 85% of patients were continuing patients, meaning they'd been supported for at least 1 year. And this reinforces Max Access Solutions as a long-term continuity of care model for patients. This slide shows how patients in Max Access Solutions are distributed across the regions. So Africa accounted for the highest number of patients for the first time last year, reflecting continued growth and reach across the region. An important point to note is that last year we had a regional reorganization which affects how we interpret the data. So India is now shown separately, and the other South Asian countries, including Nepal and Sri Lanka, are now included under Asia. Although patient numbers increased overall and across all regions except India, we noted that ongoing data strengthening efforts have improved the capture of dispensation records. This was also supported by expanded staffing in some countries, including Nigeria, India, Sudan, and Nepal. So this means that the patients tracked in our system will accurately reflect those actually actively receiving treatment. This next indicator highlights our work beyond access to medicines. Last year, 23,504 patients received accompaniment support. This refers to the emotional, adherence, navigation, and other practical support provided by Max through direct one-on-one contact with patients. In addition, 16,884 patients were supported through social determinants of health programs, which help address the social and practical barriers that can affect a patient's ability to access and remain in care. So these programs currently include patient education, last mile, helpline, day by day, and max schooling. The 48% growth in SDOH support is especially notable. It shows increasing demand for services that respond to challenges patients face beyond receiving medicines. Overall, more than half of patients reached through our other programs, so Max Access Solutions, our social determinants of health programs, or our treatment-free remission support program, also received this accompaniment support, this one-on-one support from our team, reinforcing the holistic nature of Max's model and our focus on supporting patients throughout their care journey. So Day by Day is one of our longest running and growing social determinants of health programs. It's a treatment adherence and holistic patient support program that was first launched in Latin America and has since expanded to 10 countries globally. I'll now hand over to my colleague, Liat Granati, our communications manager in Latin America, to share more about the program and its impact in Latin America.
Thank you, Alicia. Thank you, and hi, everyone. Thank you for inviting me to present this short overview of the Day by Day program in Latin America. So, Day by Day is a program that aims to provide guidance and support to patients receiving treatment through their local healthcare system. So, it was designed to focus on patients who have not received support through Max Access Solutions. The main goals of this program are to provide emotional support to patients and caregivers through phone calls, to provide education on diagnosis and treatment, and also offer coaching for treatment adherence and follow-up so patients can have more tools for the management of their treatment. So the diagnoses included in these programs are chronic myeloid leukemia, myelofibrosis, and polycythemia vera. And the diagnosis included will depend on the country. So in this case, patient recruitment can be through treating physicians. So we should engage with Max Access Solutions program physicians and other hematologists through site visits to hospital or hematology conferences. And also through local patient groups. So many patients participate in this group, which is an easier way to connect with them for the first time. A monthly contact is established with the patient or caregiver for the first 6 months, then every 3 months. So that is the way the contacts are scheduled. Another important components of the program are educational material distribution. So we deliver educational materials to patients with comprehensive information relating to diagnosis, treatments, and topic of interest. Patient meeting organizations, so patients can share experience and learn together. And also we provide support with transportation and PCR tests if available. And this will depend on, of course, on the country's availabilities of resources and the needs. So we can say that Day by Day is important since supports patients who are accessing treatment through local healthcare pathways. So we support, as I mentioned, non-Max Access Solutions patients. And it's important because local access to medicine does not always remove the other barriers patients face. So patients still need support with adherence, emotional well-being, education, and navigating health system so they can stay on treatment and remain in care over time. Day by Day is currently active in 8 countries across the region. And we are supporting today 557 patients. And these countries were launched this year, actually. Peru, El Salvador, Guatemala, and most recently Venezuela. And we expect to launch 2 additional countries during this year, the Bahamas and Ecuador. And for this year, our goal is to reach 1,500 patients in Latin America. Next one, please, Alicia. Now I would like to share a patient story and introduce Sandra, 62-year-old patient from the Day by Day program in Chile. So she lives in Santiago with her partner and youngest daughter. and some of her hobbies include photography, Reiki, and volunteering, which have helped her maintain a positive attitude throughout her journey. She had been working from home for an IT company for several years, and she was diagnosed with CML in 2014 after overcoming thyroid and breast cancer. And she's currently covered by FONASA, Chile's public health insurance system, and over the years, she has received multiple line of therapies. Next one, please. So Sandra joined the program in 2015. Her physician submitted the application form, and then we started contact with her. As soon as she shared her interest in helping other patients, and she wants to be involved in every possible initiative. So in that moment, I was working in the program, and I invited her to the local NGO meetings jointly organized by this program and the Max Vida Patient Organization, which is the national patient group that works with these patients. And she started to collaborate with both organizations. So she actively participating in campaigns, helping to organize patient meetings, and she supports any other activities required by these two organizations. And after many years as a board member and director, she became president of the local NGO Max Vida at the end of 2025. So over the years, she has gained expertise in CML. For example, she now understands how to interpret a PCR test result. She has participated as a patient advocate in different activities, including CML and CLL Horizons, and she actively supports patients and their families in Chile. So next one, please, Alicia. And to conclude, I would like to share a quote from her with you. She says, living with CML has been a challenge, but also an opportunity to grow and appreciate learning. I have learned that resilience, support, and a positive attitude are critical to overcoming any adversity. My message is that regardless of diagnosis, it is possible to live a full and meaningful life. To all those who are fighting this disease, I say that you are not alone and there is hope. Thank you.
Thank you, Liat. Okay, moving on to our next indicator. So this indicator looks at the diseases and treatments supported through Max's programs. So last year, we supported patients across 15 diseases, up from 11 in 2022, and provided access to 17 treatments across our programs. CML continues to represent the largest patient population, with more than 31,000 patients supported, followed by GIST, breast cancer, renal cell carcinoma, Ph-positive ALL, and chronic lymphocytic leukemia. Our one important development last year was the addition of a new disease area, ALK-positive anaplastic large cell lymphoma, and this reflects the continued expansion of our model to reach patients across more conditions where access to innovative therapies remain limited. This indicator, time on treatment, is one of the strongest ways we can show sustained impact for patients. On the left, we highlight data from our two long-standing programs, CML and GIST. Among active CML patients, more than 2/3 have been on treatment for at least 5 years, and almost half have been on treatment for at least 10 years. The median time on first-line imatinib is 10.4 years. For GIST, almost 1/3 of active patients have been on treatment for at least 5 years, and 10% have been on treatment for at least 10 years. And the median time on first-line treatment is 2.6 years. Then the table on the right shows the median time on treatment for active patients across our other key diseases and treatments. Overall, this indicator reinforces Max's model is not only about helping patients start treatment, but supporting long-term access and continuity of care over time. So here we have a time and treatment figure for CML, where we show the percentage of active cases, so patients who are currently on treatment, as of the end of last year by treatment start year. So patients who are actively on treatment at the end of 2025 are shown in orange, and patients on second and third line treatments are shown in green. On the far left, we have all the patients who started treatment last year in 2025. Of the CML patients who started treatment last year, 96% are still on treatment at the end of the year, 90% of whom are still on first line, and the remainder who had progressed to second or third line treatments. And then on the far right, we have a bar representing all the patients who started treatment 23 years ago in 2002. And of all the CML patients who started treatment in 2002, 15% were still on treatment at the end of last year. So the main message from this figure is that Max is supporting long-term continuity of care for patients. We see patients who started treatment many years ago who are still active on the program today, including cohorts going back more than 20 years. This figure also highlights the true value of access to additional lines of treatment. Most active patients are still on first-line imatinib, but some have moved on to other second and third-line TKIs over time. That ability to support treatment change is critical for keeping patients in care over the long term. So we also developed the same figure for GIST, our other long-standing program, and this is included in the full report. I won't go into this in detail. Once again, reinforcing the importance of sustained access, but highlighting the difference when patients have fewer lines of subsequent lines of therapy available. This indicator shows the median time from diagnosis to first-line treatment. Overall, results are generally stable or improving in our more established programs. It's important to interpret this indicator by disease context. So some diseases like GIST require surgery before treatment starts. So a longer timeline does not always mean there was a delay in medicine access alone. Notably, for breast cancer, the median time from diagnosis to treatment continued to improve, decreasing from 805 days when we launched the program in 2023 to 455 days last year. This higher median is largely due to many patients being diagnosed years or months before the program had launched and before they were enrolled. The downward trend suggests the program is maturing and reaching patients earlier. And the key takeaway from this indicator is that time to treatment reflects more than access pathways alone. It's also influenced by broader health system factors and the nature of each disease. However, this indicator helps us see where additional support or health system strengthening may be needed. So moving on to our second objective. So objective 2 focuses on the health system's work that helps make access possible and sustainable for patients. This includes expanding diagnostic capacity, training healthcare professionals, strengthening site readiness, building partnerships, and ensuring our programs have the systems and quality controls for effective delivery. So our first indicator in this objective shows the geographic reach of the Max Foundation's programs. So in 2025, Max reached 84 countries in total, including 78 countries through our treatment access program, Max Access Solutions, and 6 countries through social determinants of health programs alone. This work was supported by 377 treating institutions and 483 partner physicians. We supported patients in Lesotho for the first time. Last year, we also saw local adoption of programs in Morocco and North Macedonia. Local adoption means that access has shifted from Max support to a local pathway, such as government programs or other local mechanisms. This indicator is important because it shows the scale of our global reach and helps us measure progress against one of our key strategic goals, which is expanding access across more countries. Importantly, we're not only about reaching new countries, but also deepening access within existing countries by introducing new treatments. So last year, patients in 17 countries gained access to a new treatment through Max Access Solutions for the first time. And this included treatments for CML, breast cancer, GIST, and non-small cell lung cancer. Reaching patients in a new country is a major effort and requires close coordination across partners, local teams, physicians, institutions, and government stakeholders. I'll now hand over to Kathy Skeepers, our region head for Africa, who will share the case study of Lesotho and what it took to bring access there.
Thank you, Alicia, and thank you everybody for joining. Maybe just a quick note on the city before I go, a very personal story. of a young boy I met in 2012 at a hospital called Donald Gordon here in Johannesburg in South Africa. He was 12 years old and he was sent to South Africa to seek a diagnosis and treatment for a disease nobody could know or didn't know about. He was diagnosed with chronic myeloid leukemia without a family member next to his bedside. And the prof treating him at that time contacted the Max Foundation and said, if we give this boy treatment and send him home, will we make a difference? And at that stage, we felt every patient has the right to treatment, and who are we to decide on this boy's circumstances? He was issued with medication and a note to the family with the best description we could give on the treatment regime. And he left South Africa to go back to Lesotho, where he was from. And we actually did not expect to see him again. But lo and behold, 4 months later, he arrived back at the hospital and we got to learn more about him over time. And the story was that his mother sold chickens. She grew chickens and she sold the chickens within the local community to get enough money together so she could send her young boy on a bus across a border to another country to continue on treatment. And he kept on coming back to the clinic for at least 2 years, at which time we lost contact to this poor young man. So when Alicia was showing the figure of 15% of patients from 2022 still on treatment, I'm aware that there are patients and several barriers that prevent patients from continuation of treatment, and that is due to where they live. Lesotho, for those of you that don't know, is landlocked by South Africa, so it's like a small little island within a bigger country. They are a kingdom with a very small population of only 2.3 million, with a really interesting estimated GDP of about 2.3 billion. But most of that healthcare is going towards infectious diseases, primarily into HIV and primary healthcare. And what many of us knew, but was highlighted with the COVID crisis, is the minute there was a global health threat, the borders were closed. And everybody in Lesotho were pretty much stuck within their own system. All the cancer patients that traveled to South Africa previously, all the patients with rare diseases and all the patients that required special or specialty care didn't have anywhere to go because the Lesotho healthcare system was predominantly primary. So in 2022, a very proud moment for the country when they appointed their first oncologist. She's actually a doctor from Lesotho that went and studied outside of the country. And that brought amongst the change of wanting to establish treatment in Lesotho itself. But several barriers presented that. And again, the focus and priority of ministry. However, another crisis, the withdrawal of the USAID funding, highlighted the need for the ministry to actually act as an independent state and develop systems themselves for their own people. So when we were approached by the country physicians and partner organizations to see if there's something we can do in Lesotho, we needed to align very closely with the country's priorities and needs. Knowing what we know in the Max Foundation, know how to establish programs and how to bring treatment to patients, we also needed to make sure that what was needed in the country and that it would serve the system and not overwhelm it. So it was absolutely a thing about sitting with the ministry, sitting with the physicians, and co-designing a program with clear intent and outcomes that could be co-owned by the ministry and eventually in the future, hopefully owned by itself. Next slide, please. So for us, understanding the local capacity and infrastructure is super important when we start. And obviously, as we could have guessed and know, there's very limited oncology infrastructure in the country. The first oncologist, as we said, came back into the country in 2022. There's no electronic health systems. There is no budgeting or forecasting done specifically for this area or treatment, therefore no diagnostics, no specialists trained and no medicines available. And there's a very strong dependence still on external partnership despite this critical need to be independent. And of course, as we've said, with several factors happening, COVID and the withdrawal of international funding, there was a big impetus from the ministry to shift cross-border care back into the country. So we understood all these needs, and together we could then design outcomes and a program that would fit the country at the level it is. Next slide, please. So I'm very happy to say as we sit here today, and it's almost been 1 year since the first treatment for chronic myeloid leukemia was delivered into country. I'm very proud of this fantastic lady in the photo, Dr. Kabelo Maputswa, that stood up for the people and said she wants to bring treatment home. And at the moment, we are effectively supporting 10 patients within the country of Lesotho with chronic myeloid leukemia. We are at the moment starting to look at the intervention of supporting the diagnostics for these patients specifically, so that even more patients can be identified within their home state and also then receive the subsequent treatment. We are gathering the electronic patient data through our patient electronic tracking system, which we will also share and are sharing with the Ministry of Health, so that for future program scope, they can start forecasting and doing demand planning. So when they are at a stage where they can take local ownership for procurement and do that, they will be ready to understand the trends and what is needed. We work closely in partnership with local stakeholders and partners as well as international partners so that we continuously review pathways and prevent duplication. I think everybody goes with great intent, but we should understand that we could achieve more together than each by themselves. And in Lesotho, we've really seen the benefit of these partnerships. And then continue to review the patient journey and the needs. It's not a solid deal, I want to say, when we start the program to continue on the same path, because continuous changes within the political state, the ministry's capacity, and even within the local health system makes us need to be agile and adapt to whatever is happening. But we look forward to sharing a new update with you next year as we continue to expand in Lesotho. Thanks, Alicia.
Thank you, Kathy. Okay, we'll keep moving. So our next indicator looks at diagnostic and monitoring tests provided. So last year, Max supported 11,475 diagnostic and monitoring tests across 43 countries. That's a 15% increase from 2024 and the highest level shown in this 5-year period. So these tests include several types of diagnostic support. So one important area is PCR testing, or polymerase chain reaction testing. So this is a molecular test used to detect and monitor disease markers, including the BCR-ABL marker for CML. So through our collaboration with Cepheid, partner institutions in several countries can access the Gene Expert PCR testing at no cost or at preferential pricing. We also support subsidized local testing and spot-on CML testing through our collaboration with the Radich Lab at the Fred Hutch Cancer Center. So spot-on CML uses a dried blood spot method where a few drops of blood are placed on a special paper and sent by mail to the Radich Lab in Seattle for PCR testing. Our key developments last year include the continued expansion of Strat4 for breast cancer biomarking testing, with the validation for Strat4 testing completed in Cambodia and ongoing work in Sierra Leone. We also reached patients in 3 new countries through diagnostics for the first time: Eswatini, Gambia, and Sierra Leone. Overall, this increase reflects both rising demand and improved in-country diagnostic capacity. Expanding access to diagnostics is essential because patients need timely diagnosis and ongoing monitoring, particularly for diseases like chronic myeloid leukemia, to receive the right treatment and stay in care. So breast cancer diagnostics is an area Max has been working together with partners to strengthen over the past few years. And Strat4 is an important part of that effort to improve access to timely biomarker testing. So Strat4 is a Gene Expert-based breast cancer biomarker test that helps identify estrogen, progesterone, HER2, and Ki67 status. And these are essential for guiding breast cancer treatment decisions. It's especially useful in settings where the gold standard immunohistochemistry testing is limited or difficult to access. I'll now hand over to Mei-Ching Ong, our region head for Asia and Eastern Europe, who will share more about our Strat4 implementation and validation work in Cambodia.
All right. Thank you, Alicia. Hi, everybody. So in the next few minutes, I'm going to share how we strengthen the breast cancer diagnostic capacity in Cambodia by bringing the Gene Expert Strat4 assay on site. Next slide. So we all know that for breast cancer treatment, it depends heavily on HR and HER2 testing with immunohistochemistry or IHC as the standard. But the capacity and accessibility is limited across the low and middle income countries. So in Cambodia specifically, the IHC cost is very high and largely paid out of pocket, which you could imagine that many patients simply cannot afford. So when we launched the treatment access program for HR positive and HER2 negative advanced breast cancer, we quickly realized that strengthening local diagnostic became a priority to enable timely and appropriate treatment. So our aim was to establish reliable, accessible, on-site biomarker testing within the hospital. Next slide. Now let's look at the process that involved. So the whole process took 17 months from the initial engagement in May 2024 to completed validation in October 2025. So we work in 3 stages. First, the setup, which covers the site readiness, procurement, installation equipment, and also lab verification. Then second, the training. So we had both virtual and on-site, which by the hands-on of technical support from the partnering diagnostic company. Then the third phase, the validation, and it was done using the standardized protocol, the FFPE samples to compare against the IHC for ER and also HER2. And the result was strong. We got a 100% of concordance for ER and also 90% for HER2. The 2 HER2 discordant cases were reviewed by the external pathology expert, whose findings supported the Stratfor result. So this gave us a real confidence in the local capability. Next slide. So now, what was the outcome and the learning? The outcome was clear. 40 samples were validated, 20 for ER and 20 for HER2. And the hospital has established a fully functioning local Stratfor testing capacity in October last year. So what does this change? I think this is a very important question that we all need to kind of ask ourselves. This has reduced cost and also turnaround time barriers, avoid treatment decision based on the unknown biomarker status, and connects the eligible patients to treatment through max access solutions. The key learning is that the molecular diagnostic can succeed in low resource settings when implementation is carefully planned, locally embedded, and well coordinated. By linking the diagnostic directly to the treatment access, we improve both timelines and also quality of care. So this experience in Cambodia gave us a replicable model for expanding biomarker-guided care in another country in the low resource setting, which would definitely strengthen the local health system and make a positive impact to patients. Thank you.
Thank you, Mei Ching. Okay, so looking at our next indicator highlighting the continued growth of our treatment-free remission support program for eligible CML patients. So treatment-free remission, or TFR, allows select patients who have achieved a sustained deep molecular response to attempt stopping therapy. However, this can only be done safely with frequent molecular monitoring and close clinical follow-up. Last year, MAC supported 125 patients across 9 countries, and that's nearly double from 2024. The program expanded to El Salvador and Nepal. By the end of 2025, 71% of patients had remained active on treatment-free remission for at least 6 months, and 50% of patients for at least 12 months. We published results in the New England Journal of Medicine showing that TFR can be safely supported within MAC's programs when patients have access to appropriate monitoring and clinical oversight. Importantly, this program is helping move CML care beyond access to medicines alone towards safe treatment optimization and long-term outcomes for patients. Our final objective focuses on indicators that measure the value of Max's investments, including operational efficiency, risk management, and the broader impact of our programs. So the one indicator I'll show under this objective shows the estimated strategic investment of medicines distributed through Max Access Solutions. In 2025, Max distributed $395.9 million in medicines, a 10.4% increase from 2024. Medicines represent the largest share of resources mobilized through Max, and in 2025, these medicines supported over 38,000 patients across 78 countries. This indicator is important because it shows the scale of resources Max mobilizes through partnerships and how these resources translate directly into treatment access for patients who may otherwise go without. So to close, this final snapshot shows the scale of Max's 2025 impact across key indicators and, importantly, the growth across these indicators. As we close, I want to emphasize that the numbers in this report represent only one part of the Max Foundation's impact. As a patient-centric organization, we know that behind every data point is a story of someone that has been helped. These stories go beyond metrics. They represent lives changed, care continued, and systems strengthened. Our M&E work helps us measure progress, but it also helps us ask where gaps remain and how we can adapt to ensure that no patient is left without the treatment or support they deserve. It goes without saying that this work would not be possible without our global community of partners and supporters, all of you who share our belief that access to treatment is a human right, and that because we can help, we must. So thank you all for joining us today, and thank you for your continued partnership in making cancer care more equitable. I'm now going to invite my colleague Charmaine Vasquez, our senior grant manager, to moderate the Q&A. I will open up for questions. Please feel free to share anything in the chat. Mei Ching, Kathy Liat, and I will do our best to address them. Thank you. And I will stop sharing.
Thank you, Alicia. That was really interesting to see the progress. We don't have any questions in the chat quite yet. Just a reminder to the audience, please write questions that you might have for our panelists in the chat. But in the meantime, I'd love to direct one to Kathy if I could. Kathy, I know that Max is looking to ramp up M&E efforts in your area in the near future. And I'm curious if there are any metrics that you're not currently tracking that you are hoping to track in the future with the ramp up of those efforts.
Thanks, Charmaine. That is an interesting question and a hard one because I think data tells an interesting story of trends and needs. So I'm very grateful to be partnering with Alicia on this so that we have the correct metrics to be able to forecast and do the correct planning for what is needed and be strategic in what we develop as interventions. For the region, as far as I have it, we are going to have an M&E person based within the region very soon to help us identify the right metrics to be able to share the right data. I also just want to say, in terms of M&E, metrics is really important, but it's also important to take into consideration the context and scope where it comes from. As we look at data, it gives us a very direct picture, but it also makes it, that's why we share the stories of the patients behind the numbers. So as much as we do the metrics on M&E, we need to make sure that these metrics still line up with the actual people we serve so that there needs to be this connection. So in terms of what metrics do we need as we expand our programs, as we are actively doing in continuing our partnerships and engagements, those metrics will obviously start growing. And obviously, as we grow, there are some metrics along the way that we will also have to drop off. As Alicia said, in some of our current data, there's some we need to merge, others we no longer look at in the same way.
Thank you, Kathy. Appreciated. We had a couple of questions added to the chat here. This one is from Joan from the CML Busters Foundation. And if I can summarize here, hopefully I gather it correctly. But I think what Joan is asking is, are we measuring the potential reach versus the actual reach? For example, comparing global disease prevalence with the number of patients served and using that gap to assess program impact.
Yeah, I can take that one. Thank you, Joni.
Mhm.
So we recently did an analysis looking at this potential reach or reach within countries, really estimating the CML prevalence within each country. And then as you know, and that is the denominator, and then we were looking at our reach as the numerator. So we had that metric really to look at this reach for CML specific to the prevalence. What it showed was that reach, um, or this analysis is sometimes known as a penetration analysis, but reach was really varied between countries, and it kind of led us to asking questions of why that was different. Was it diagnostic capacity? Was it physician engagement? And there's various reasons why reach was very different in countries even of similar population size. And so we're doing a further analysis to kind of look at some of the factors that might impact reach. But we did do an analysis sort of looking at that potential reach or the denominator, I think, which is what Joni's asking of what the estimated prevalence in each country is for CML. And hopefully when we've done this further analysis, we'll publish that or include it in the report next year.
Thank you, Alicia. We also had a question from Dr. Silva. What are the criteria and conditions needed to enter into treatment-free remission?
Yeah, so we started our treatment-free remission program in 2021, and it was the first time that we know that treatment-free remission has really been attempted in low and middle income countries. So we looked at all the guidelines, in the US and Europe, used that, but used a slightly more conservative approach. So the key criteria are that chronic myeloid leukemia patients are on first-line therapy, have been on treatment for at least 10 years. So that's a slightly more conservative criteria than what's used in a lot of high-income countries. We also had to ensure that the countries we were supporting patients for treatment-free remission had very, very reliable monitoring, diagnostic and monitoring testing. So they had at least two methods for testing. Physician engagement, so being able to engage with physicians as well as with the patients in that country, communicate with them effectively was another important criteria. We've listed all the criteria in our recent publication in the New England Journal of Medicine. And I can share that with everyone in the chat as well.
Great. Thank you so much. This next one is a question from Mabel. It's actually for Kathy and Mei Ching. Mabel is wondering if the changes in USAID programs affected any of our work, and if there was no effect, what was the impact on the institutions themselves?
Mei Ching, shall I go first and you can jump in?
Go ahead.
I can say that yes, there's an indirect and direct impact. The direct impact I personally see within our laboratories. A lot of the laboratories supported by the USAID was for the HIV and TB programs, and that funded a lot of the infrastructure, the equipment, but also the staff, so the lab technicians and to an extent the pathologists. With the withdrawal of the funding, the laboratories closed. And as we know, with chronic myeloid leukemia, we use the same platforms, the gene expert machines, and the same laboratories for testing. And we currently find ourselves that our patients that used to be able to refer to these labs because they had the infrastructure were no longer available or open. It also had an impact on some of the breast cancer programs where we knew we could previously perhaps get access to limited or to some extent immunohistochemistry. But again, as I've just referred, with the withdrawal of that funding, the laboratories is usually impacted. The secondary or indirect impact of this is investor or donor trust. As we say, kind of there is with the USAID withdrawing, several other funders followed suit and removed their programs and funding from these countries. That makes ministries look at us, and even some of the institutions and physicians initially were very scared, and there was almost a mode of crisis and saying, well, is the Max Foundation going to do the same? Are they also going to just withdraw without giving us a heads up? And the good news of that is, and I think this is the good spin-off, is that there is now more impetus from the ministries to be closer and more involved in the design of these programs, but also take ownership to an extent, understanding that it's not forever. So there's the good and the bad. Mei Ching.
Right, we're kind of like saying the similar things as well, so I'm not going to repeat that. But one of the things that really struck me was I had this conversation last year. I had this conversation with a community in Cambodia. So this person is kind of like doing some global health work as well. So what he was saying is really interesting. So he says that in Cambodia, Laos, in this part of the world, one of the programs that heavily heated by this USAID is the nutrition program for kids, like the food, the necessary, for the kids and for these families with kind of like poverty and all that. So once that actually stopped, then the basic nutrition become a problem. So we might not able to see it immediately, but we are all kind of like be ready and suspected that these will probably have a long-term impact. Or we would actually see this, like probably like in another 2 years or so, because let's just imagine, like kids grow up with like not enough nutrient, not enough food, they're not the kind of like so-called a healthy food or whatever you call it. What would be the impact to the future health? I think that's a lot. It is not only on physical, but the mental and all that, because kids supposed to go to school and all that. You all need kind of like, the kids need focus, in the classroom and that. So I think the summary is definitely have a big impact. And it all kind of like all connect the dots together. And I think when we look at health, we can't only look at one specific segment, because social determinants of health, education, literacy, access to facilities, and all those things are all interrelated. That's why I think the Max Foundation, we kind of like having the social determinants of health program as well to complement what we are doing on the treatment access, as well as, that not only thinking from a patient perspective, but also the healthcare professional. I think they are the same. They are kind of like having this like big pressure as well, that sometimes we're just kind of too focused in one community, which is patients, but people forget about caregiver, nurses, the doctors, or even the people in the laboratory. So I think in a nutshell, yes, that's impact.
Thank you both so much. We had another question from Sean, and I think what he's asking is beyond the social determinants of health metrics that we shared. Are we tracking how well these programs are working from a quality and patient satisfaction perspective? I think that one's probably best directed to Alicia.
Sure, yeah, we are deepening how we evaluate our social determinants of health programs. As Liat shared Sandra's story, we know from our patient stories the impact that these social determinants of health programs have on patients. And now we're trying to show that more with numbers and with evidence. So as an example, for our day-by-day program, we are planning a evaluation to look at the impact of the program, really using tools to measure quality of life and adherence, because those are what we think the main benefits or outcomes of that program is. So yes, we are, strengthening some of the metrics and the work that we do in our social determinants of health programs, while also acknowledging that, a lot of it requires patient surveys or asking patients to participate in measuring this. And so we need to balance what we ask of patients with measuring and getting the numbers that we need.
Yeah, I want to add something there. Can you hear me well now? Better than before?
We can hear
I
you.
have. Okay, I'm so sorry. It's happening, but yeah. And also in the education program, we share some surveys with the patients after when we send educational materials. We share them some surveys so they can provide some feedback about the material they are receiving, about any kind of information they need. So we can evaluate like the patient satisfaction through those surveys, and that is one another example of how we are doing with SDOH. We are asking the experience of our patients. Yeah.
Thank you both. We're running a little short on time, so I'll wrap up, I think, with one more question. Alicia, I'm curious, in putting together this M&E report, what metric or metrics were you most surprised by?
Yeah. I mean, the biggest increases in terms of patient numbers were those supported by the social determinants of health programs and our diagnostic programs. And so I wouldn't say surprised, but I think it is nice that the numbers reflect all the work that we're doing around access to medicines, in the health system strengthening particularly with diagnostics for diagnosis and monitoring of patients, as well as the social determinants of health programs, which often require a lot of effort from our team. Patients programs like Day by Day and patient education is directly the work of our team members in the country, and it's nice to see those numbers reflect all the work that's gone in around the access to medicines.
Thank you so much. We don't have any other questions in the chat. Feel free to email us or follow up with any additional questions afterwards. We're always happy to share.
Yes, thank you all for joining, and we will share the full report, and it's also posted on our website.
Thank you, everyone.